everyone, and welcome to an episode of the Heart of Dentistry podcast. Jamie Marbo Nichols and myself, Brandy Hooker Evans, are thrilled to bring you part 2 of a phenomenal conversation that we're having with Miss Dilaine. Jamie, can you tell us a little bit more about our sweet friend here today?
Yes, Dilaine Gleggy is the coaching guru on coding and documentation, both medically and dentally. And I happen to also be really close friends with her. I'm thrilled to have you back, Dilaine. You're just a wealth of knowledge in every practice. We need about 200 of you because every practice needs to talk to you and get you in their office coaching them on these things, these topics. So last time we talked about documentation from the more of the hygiene standpoint, the D4910 perio maintenance. So today what we want to do is take something that you see that is poorly or not documented correctly at all from more of the operative side of things. So what can you bring for us today for our listeners to hear and learn from?
Thank you, Jamie, and thank you for your kind words. It's an honor to be back. So as we continue our conversation on requirement of specificity in our documentation, that's what our clinical note lacks. From a restorative perspective, we do not document the extent of decay. And while we're talking about restorative piece, this applies to a hygienist as well, because where are those restorative needs typically diagnosed? At the hygiene visit. So what is lacking from that perspective? Tell me about the extent of decay. Is it limited to the enamel? Or does it extend into the dentin? Or is the pulp exposed? I need to know that level of specificity when we're talking about dental caries. And, we've never had to do this in dentistry until recently, but we have to ensure quality patient care. We have to document why was this procedure required. And we're not talking about, applying diagnosis codes necessarily. Even though we may not be required at this point to apply diagnosis codes to all dental claims, we still are being held accountable to that level of specificity in our clinical note. Often,
do you think that's coming just really quick? Is that because I've heard that being tossed around that, like the medical, we would have to have a conditions code?
It is absolutely, but it applies to dentistry too. That's how we ensure that quality of patient care. You have to tell me why was a procedure necessary, prove medical necessity. What was wrong with the tooth, or what was the condition you're treating? Well, in this case, you're treating the condition and disease of decay, caries, dental caries. And, when I say we're being held accountable, the posterior composites are a high audit area. Well, I have had dentists give back close to $60,000 for one audit from one payer because his documentation for occlusal caries, the bite wing doesn't show that those caries extend into the dentin, right? But we can see it, we can feel it, and when we go to remove the decay, we see the dentin. What all his documentation showed was occlusal caries. He didn't tell me the story. Again, we're storytellers.
Yeah.
And he did not have intraoral image to support that. And of course, the bite wing didn't show that. So in one audit, 10 patients, 3 years, $59,000 was given back because he could only prove that the decay was limited to the enamel. So the payer allowed the dentist to keep any amount he would have received for D1352 code, which is preventive resin restoration, where the decay is limited to the enamel. So even if he had had that intraoral image, his documentation would have needed to be more specific. The decay extended into the dentin, and by taking an intraoral photo, it proved that it was supported what he would have written. And so,
I'm sorry. Go ahead, Dilaine. I thought you were.
When the treatment planned and diagnosed at the recare visit, the hygienist needs to document what they see today. Now, that level and that extent of decay may change, of course, and it needs to be documented, not in one line item, number 30 occlusal, 19 MO. I need to know more about what's wrong with each tooth. And then when the patient comes back for treatment, that same level of documentation needs to be there, because somebody, whether it's an insurance payer or a patient, and whenever they look at that chart note, they only care about what's documented today. They're not going to go back through your record. Well, it was documented in hygiene, so we're okay. No, each visit, you got to show why you recommended the treatment and also show why you did the treatment.
And that's what I was going to ask you when I started to interrupt you is, so it could change during treatment. So you're suggesting at the time of the exam, whoever is the assistant or the hygienist that is with the doctor, and the doctor diagnoses decay on a certain tooth, that they take an intraoral image along with the radiographs, and they then would document the level of the extent of the decay. And then if it changes, they would then, during the actual procedure, and of course it'll most likely be deeper, but maybe it isn't, they would then they would change or reiterate what they initially documented, take another intraoral image while the tooth is opened if it's changed, or what do you recommend there?
Not necessarily on the hygiene visit where it's diagnosed. I don't necessarily recommend the intraoral image at that visit, but at least a documentation of what they see. It's not going to hurt to do an image at that visit. Where it's crucial is when you can prove with an image that decay and prep extends into the dentin, because coding guidelines for CDT for posterior restorations, the prep and the decay must extend into the dentin, or it can't be called a restoration. Okay. That's where the issue lies. So.
I wanted to clear that up. That makes sense. Okay. And the doctor has to actually say to his assistant or hygienist what he believes at that exam is the extent. Because if he doesn't say it and he leaves the chair and then they write it down, that'd be like them diagnosing. So we want to make sure that the doctor is saying out loud and the patient hears the extent of that. Is that correct?
Yes. That decay is into the dentin. I need an appointment. I need to do a restoration on this tooth, a composite or amalgam, if we do amalgams anymore. So, yeah.
Well, I think if we practice this, it's just like I didn't used to call the perio chart out loud, and now I do every time. We will get more efficient so that it isn't taking up so much time, because that's one of the things that comes into play when we look at note taking as well as the conversation that's happening during the exam. We want to be cognizant that we're running and shaking, but we have to be doing a great job while we're moving quickly and not forget to do these very specific items that are, and coming up in more than one way. Like you said, this is important for insurance reimbursement. This is important for legality. And it's also important for continuity of care for our patients. So, Dilaine, this is so exciting. I feel like I want to just pick your brain all day long.
Oh, yeah. Welcome to my world.
I'm happy to let you do that anytime.
Yeah.
Is there anything specific as clinicians, the doctors and hygienists are listening to you today? Is there one good nugget you could give us to just start today? It can feel a little bit overwhelming, but what can I do today with my 2 p.m. patient?
So I would start by really going back and doing random audits of your own chart notes and that of other clinicians in your practice, and have other people read them, look for ways you can improve it, and build upon that information. It's like you said, the more we practice, the more efficient we get. But we honestly cannot afford not to take the time for accurate documentation. Accuracy and documentation does all the things we've talked about. And as a bonus, accurate documentation ensures adequate and accurate reimbursement.
Yeah. And also it goes to a lot of times, like what we were talking about with the coding on the 4910, lots of hygienists, as Brandy was pointing out, it's so the continuity between the providers is there, because instead we'll sit there and we'll complain about, I don't know what they talked about. I don't know what they did. It's like, did they talk about, and then sometimes you get to the chair and you are with the patient and they're saying, well, remember last time the girl or the gentleman that worked on me said something about this tooth up here, and you don't see anything about it. And you're kind of looking dumb because you don't know what it's about. So rather than complain about it, there's like so many reasons that Brandy brought up that is so true. So let's get this in action. And instead of us pointing fingers, let's just say from now on, here's what we're going to do. Here's the documentation. Here's the system. And everybody's going to follow it. Everyone's going to be a part of finding out what it is you get frustrated about so that we can do all those three things: protect ourselves, do the best thing to be, have continuity, and also make sure that this would hold up in a court of law if it ever had to.
Perfect.
Yes. So, okay, how can our viewers get a hold of you if they would like to have you come in? Or you do a lot of virtual training too, but in workshops and seminars. I mean, I always see that you're gone somewhere in some office or some workshop. So how can they get a hold of you if they'd like to hire you personally as their consultant with this great topic that we're talking about?
I can be reached through my website, which is tidewaterdentalconsulting.com. You can also call me at 704-796-0101. And I would love to have a conversation of how we can up your storytelling game in your practice.
Great. Thank you, Dilaine, so much for joining us and taking some time out to help educate not only our viewers and listeners, but also Brandy and I. Yeah, as coaches, I always learn from you something every time I talk to you.
Thank you so much for having me.
Okay, have a great day.
Thanks, everyone. We hope you have a brilliant next appointment with your patient, and good luck looking at those charts.